concerning childhood cancer, its awareness, its treatment, and how it comes about, and any questions or myths you will need dispelled about childhood cancer. You could ask your questions here today. You could send in your questions to the chat box, or you could send them directly to the host. The session would also be recorded and streamed live on YouTube for other members and other people to send in their questions as well. So I think we have two of our panelists who have joined in already. I think I can see Dr. Felix Alakaloko, is a consultant pediatric surgeon at the Lagos University Teaching Hospital. He carries out surgeries, a surgical oncologist, carries out surgeries on children with diagnosed with cancers. Thank you very much, Dr. Alakaloko, for joining in.
Thank you, Dr. Maliki.
I think we also have Nurse Unwokoro Rachel. She's a nursing officer at the Alima Ata Pediatric Oncology Ward also at Lagos University Teaching Hospital. She sees to the nursing services of children with cancer, and she's also been a longtime friend of the foundation. Thank you, Nurse Rachel, for joining in. So while we wait for others to join in, please, you can send in your questions. If you had any questions prepared, we already have some of them in, but you could send in your questions, and then we would start to answer those questions. I also have with me Dr. Layo Fagbemide, who will be moderating with me. I am Dr. Adiola Maliki. My apologies. I'm Dr. Adiola Maliki. I'm a medical officer and a volunteer with the Cast Cancer Foundation. Okay, so while we wait for the other panelists, there's a question already in for Dr. Alakaluko. Somebody asked for children, because apparently she had a relative who was told that the child had cancer, and the child wouldn't be able to have surgery in time, and they would have to wait for a bit for the child could have surgery. So she was asking, how early can surgery be carried out on on children who have had cancer? What's the earliest a child can have surgery for a child that has been?
Thank you very much, Dr. Maliki, for starting. I think before we go into the question and answer session, maybe we need to just take some few information from the Tdcf team, so that before we go there, so that we could have more of other people joining. I think people are still on the road joining. So thank you. Over to you, Dr. Maliki.
Thank you, Korede. So briefly, we would have welcome remarks from the programs head and coordinator at the Cast Cancer Foundation, Mr. Korede Akindele. We'll be talking about the International Childhood Cancer Awareness Day, how it's come about, and then some brief information about Tdcf.
Okay, thank you, Dr. Maliki. Hello, everyone. Thank you very much for joining us in the International Childhood Cancer 2023. My name is Korede Akindele. I'm the head of programs at the Dorcas Cancer Foundation. 2023 Iccd Childhood Cancer Day is so special because it focuses not just on healthcare workers, but also especially caregivers, which comprise of families, families and friends. And every one of us, like I said today, we are caregivers. Caregivers in the sense that we are part of communities, we are part of families. So we all have a role to play. We all have something to do to ensure that children with cancer, they survive. The truth is, the statistics still remains that in high-income countries, there are 80% chances of survival, where in low-medium income countries like Nigeria, where me and you are, our chances of survival is still dangling between 30–40%. Now, this has different reasons why this is happening. So as a result, one of the reasons is low presentation, which is caused by lack of awareness. Also, we believe that Iccd, which is put together to steer global collaborations, to steer actions for more people to be aware of childhood cancer, I think it will help us in Nigeria to reduce the burden and also increase presentation and also improve survival rates. So I welcome you all to this evening question and answer session. I'll just encourage you to please prepare your questions. We have a team of experts from radiation oncologists to childhood cancer survivor, to cancer survivor, to pediatric surgery. There's our team of panelists this evening. They will be answering all questions that you may ask. So please, I would advise that you get your question ready. Feel free to use the chat. You can drop your question. If you would like to send your question privately to the moderator, please just look for Dr. Maliki or Dr. Lyle. Dr. Maliki or Dr. Fumilayo Fagbamidi. These two are the moderators, so you can even send your questions to them directly. Feel free. We're going to be having a great time to answer all your questions this evening. Once again, on behalf of the management and the children at the Dorcas Cancer Foundation, I welcome you all to this wonderful evening. And quickly before I wrap up, we will take permission that this is being streamed on our Facebook and also is being recorded for our other audience that could not join directly on this place. So thank you so much. I'm going to hand over to Cynthia Iwu for the next thing. Over to you, Cynthia.
A good afternoon to you all. You're welcome to our International Childhood Cancer Day Cancer Caregivers Workshop. So my name is Cynthia Iwu, and I'm the head of admin and finances at the Dorcas Cancer Foundation. And then before we go proper into the program, I would just like to introduce the Dorcas Cancer Foundation, which is an NGO for children living with cancer. So the Dorcas Cancer Foundation was established in September 2015 and was incorporated under the laws of Federal Republic of Nigeria in March 2016. And it was founded in memory of Dorcas Adipiton. So that's where the name Dorcas came from. And she died of osteosarcoma, which is a bone cancer. And it was founded to support other children living with cancer in Nigeria and dedicated to ensuring that childhood cancer survival in Nigeria catches up to the developed world. And at the foundation, we are non-racial, we're non-religious, and a non-discriminatory organization. And so many lives have been touched by our programs and support in one way or the other. So at the foundation, we have 4 key points in our agenda, which is our research, early detection, accurate diagnosis, prompt and proper treatment. So what we do at the foundation is based on these 4 key points on our agenda. So looking at my screen, you can see we've supported over 60 children so far at the Dorcas Cancer Foundation. We have more pictures. So if you would like to see more of our children, we have them on our website, our social media pages, the children we've supported so far, but this is just a few of our pictures. Then we also have some of our major programs at the foundation. We have the Look Again campaign, which we've done in 3 states in Nigeria, Lagos, Ogun, and Oyo states. These are just a few of our pictures. For more images, feel free to visit our website also. We also have a PDROC, which is a Pediatric Radiation Oncology Bootcamp. So the first one was held last year, and these are just our impacts so far. So last year we had over 200 registrations, over 200 attendees, 20 speakers from over 20 countries, and we talked on 22 topics last year for the PDROC program, and we hope to do more this year. So we also have our awareness program, which we're doing, and we do that every year during our International Childhood Cancer Day and our September Childhood Cancer Awareness Month and other months in the year, where we raise awareness about childhood cancer on social media, on our websites, radio and TV. We go for our shows just to create more awareness about childhood cancer. So at the foundation, we are open to volunteers. We have various opportunities for volunteers to join in. So if you're interested in volunteering with the foundation in any of these programs, social media, content creation, graphic design, research, grants, support group, community awareness, fundraising, treatment navigation, basically for children, and also creating content for our handbook, we are open to various opportunities. So we have our account details displayed. If you're willing to, or you're touched to support any child, we have our account details there. Thank you so much for listening. So over to you, Dr. Maliki.
Thank you very much, Cynthia. Thank you for that talk on Tdcf and on the wonderful work we've been doing. Children need our help. These children need our help, and then whatever donations and whatever resources we have at our disposal that we can use to help these children is very much appreciated. We would go on to the next session to not waste any time. We have some of our distinguished panelists already joined. Thank you for joining, Prof. Bioli Brown. So Prof. Bioli Brown is a consultant pediatrician and professor of pediatrics at the College of Medicine, University of Lagos, University of Ibadan. He is also the president of the Nigerian Society of Pediatric Oncology, NISPO. Thank you very much, sir, for joining. We thank you for your time and for joining us today. Prof. Brown, can you hear me, sir?
It was breaking, but I can hear you now.
Oh, thank you very much, sir. Thank you for joining the session today. Yes, I was just doing the introductions. I'm introducing you to the audience. We are glad to have you in attendance to be able to answer. And we hope that this will be a very educative and entertaining session. Also, we have Mrs. Olushola Akapo. She's a cancer life coach, and she'll be joining us today to answer all our questions, on what she has faced and what she has seen with interacting with children with cancer, and also for their advocacy. We also have Mrs. Adekemi Oyewusi. She's a childhood cancer survivor, and then she'll be giving us things from her perspective and her point of view, from her personal experience in managing and battling with cancer. Like I introduced earlier, we have Dr. Alaka Luko. He's a pediatric surgeon at Lagos University Teaching Hospital. Thank you very much for joining. And last but not least, we have Dr. Ayodele Rena. He's a consultant pediatrician and pediatric nutritionist expert. He's also the noisy pediatrician on Instagram, and then I'm sure he has entertained all of us with his videos and then entertaining content. He's also a personal friend of mine. Thank you very much for joining, Dr. Rena.
Thank you, Dr. Maliki.
So without further ado, we should dive straight into the question and answer sessions. We already have some questions for the panelists, and then we would expect more questions coming in from the audience members and from the Facebook streaming session as well. So if we have any questions, please, we could put this in the chat box or send directly to me or Dr. Fagbemide, so we could ask the panelists. We'll be going to the session now. So like I was asking Dr. Alakaluko earlier, one of our first questions that came in was on surgery in children. The person asked, how early can a child have surgery? So apparently a relative of hers had a child who was about 16 months old and was told she had cancer, but wouldn't be able to have surgery until the child was about 2 years. And then they were worried about wasting time and, for the cancer to grow and progress during this period of waiting. How early, so she's asking, how early can a child have surgery when the child is diagnosed with cancer? Thank you, Dr. Alakaluko.
Thank you, Dr. Maliki. And thank you, Doctors Cancer Foundation, for bringing me on board for this meeting. And I welcome everybody to this meeting. And the question is very important. And that's because a lot of people have this misconception about timing of surgery. I make bold to say that surgery for cancer in children will be done or should be done as soon as it is discovered. And the reason is because, like majority of the cancers we have in children, neuroblastomas, rhabdomyosarcomas, Wilms tumor, and the rest of them, the longer they stay in the system, the worse the prognosis, because the more the stage, okay? And you don't want a stage 1 tumor or cancer to grow to a stage 3 before you intervene. From my own personal experience, the youngest patient I've operated on that had a neuroblastoma, that case was even is reportable, is a neonate, a 3 weeks old, that presented to us with this mass in the abdomen, and when we took the patient in within that week, and the histology came out to be a neuroblastoma. So then that's a child that is less than 1 month old. So for this patient of this our colleague or our friend that is 15 months old already with a cancer, it's wrong practice to delay. So surgery should be done as soon as possible, if possible within that week. Thank you.
Thank you, Dr. Alakaluko. This also speaks to the fact that we need to have specialists in charge on board in the cancer management team, so we have the right information and the right protocols are followed in cancer care management. Before I go on to the next question, we have Dr. Iccd, who just joined us. Dr. Iccd is also a consultant, pediatrician, pediatric hematologist and oncologist at the Lagos University Teaching Hospital. Thank you very much, Dr. Iccd, for joining in. So for the next question, if I can go on, I think this question is also in the same vein as how early can children, because the person is also asking how early can children start chemotherapy? Because a lot of parents, and also in my practice, a lot of parents and caregivers are worried that their children are too young or too frail to undergo chemotherapy, and then they are worried about long side effects and complications that come about from having chemotherapy. How early, or what's the earliest age for a patient, child diagnosed with cancer, how early can they start chemotherapy? Prof, if you could help us with this question.
Well, thank you very much. Like my pediatric surgical colleague said, as soon as a child is diagnosed to have cancer, if that child requires chemotherapy, it should be given. Chemo has side effects, both in the older children or the younger children. So regardless of the age, if the child requires chemo, then the chemo should be given without regard to the age of the child. The thing to do is to give the chemo, watch out for the side effects, and manage the side effects. One beautiful thing about chemo is that for certain drugs, the dose given depends on the age of the child. So even when you are worried, for very young children, for certain drugs, not all chemo drugs, for some chemo drugs, is regardless of the age. In other chemo drugs that are thought to be more toxic in younger children, a lower dose is given for a particular age and a higher dose given for an older age based on the child's weight in kilograms. But the chemo should be started as soon as it is required in the cancer after it is diagnosed. Thank you.
Thank you so much, Prof, for clearing the air on that, because it's something that I even see rampant in my time in Luz. A lot of children who came with recurrent or metastasis down the line, patient and the parents had already noticed the cancer and had gone to the hospital. They had been counseled for chemo, but because they felt the child was too frail or was too young, they withheld, and then the cancer spread. So for those joining in, we should start cancer treatments as soon as the diagnosis is made, be it surgery or chemotherapy, as long as the treatment is being carried out by specialists. Dr. Fagbemide, are there questions you have to answer?
Thank you, Dr. Maliki. Thank you, everyone. And good afternoon, everyone. My name is Dr. Layo Fagbemide. It's been a wonderful session so far. Thank you to all our panelists. Okay, so the question is for Dr. Alakaloko. Just to further buttress here, from your experience, is the surgical outcome, is it age dependent, from all the surgeries and everything, and from your experience, all you've done and all you've seen, basically, like the younger ones, do they have better prognosis regarding surgical outcomes as compared to the older ones? So that's the question from my end. Thank you.
Thank you once again, Dr. Fagbamide. Just to answer your question, actually, it's not too easy to say that the outcome is age dependent. But what we know, and across all the tumors that we manage, is that the earlier we pick them, the younger they are, the lower their stage, and that ultimately has impact on the outcome. So, for instance, a patient that has the Wilms tumor and you are picking the Wilms tumor later around 4 years old, the likelihood that you're not female. Right. So with that, we can say that it's better when the patient is picked earlier, and but that does not mean that we don't see higher stage of patients even in younger age. Thank you.
All right,
Thank
thank
you,
you so much, sir. For Dr. Malik, please, before we go on, please, thank you so much for joining us, everyone. Thank you very much. We recognize the presence of everyone that joined. We just want to please plead with our panelists to please, if you can turn your video on so that the audience can see you when the question you are answering the questions, please, so that there can be a connection. We really appreciate. Thank you very much. Thank you. Over to you, Dr. Maliki.
Thank you, Korede. I would also like to welcome Nurse Nwokoro Rachel. She's one of the nursing officers at Alimata Alimata Pediatric Oncology Ward at Luz. Thank you, Ma, for joining. We have some questions for you too, so I'll be coming to you. But this question came in earlier, and it's actually something I come across all the time, and it's deals with associated with nutrition. So from my experience, I know that apart from the treatments with chemotherapy and radiation and surgery, supportive treatments, if a child's nutrition and calorie intake isn't enough, they come down with more side effects, there are less responses to treatments. And then there are many myths concerning nutrition when it comes to cancer care, most especially when it comes to sugar and carbohydrates intake. So, Dr. Rena, if you may, could you please clear the air on sugar and carbohydrates? What is the relation with carbohydrate and sugar intake and progression of cancer? Is it something, do they have any relation at all, or is it just something that people say that isn't true about cancer? Thank you, Dr. Rena.
Thank you, Dr. Maliki, for the question. And it's a very relevant question. I'd like to, of course, acknowledge the presence of the other panelists, especially Professor Brown, who taught me at many updates, and Dr. Kinshete, both my teachers, and then my very dear senior colleague, Dr. Lakaluku. When it comes to nutrition and cancer, the myth is that sugar feeds cancer cells, but no research has clearly established this relationship. So the simple answer to the question is that sugar does not feed cancer cells. There is no indication that cancer progresses more rapidly as a result of sugar intake. However, we do realize that if you want to draw a sort of pyramid in terms of what children should be eating, sugar should really be at the tip of the pyramid, such that they are eating only the minutest quantities. And this, of course, is because sugar can predispose to dental issues like caries, tooth decay, and sugar in excessive amounts can also predispose to, obesity and other issues that we really don't want children who have cancer to be dealing with, because the last thing you want for a child who is receiving chemotherapy is to be dealing with a dental issue like, tooth decay or a carious tooth, okay? But the simple answer is that children because the peculiarity about children is that, children by nature will want to engage in the other things that their colleagues are engaging in. So if there's a birthday party, for instance, or there's a family outing and there's candy and there's ice cream, it's really difficult for you to say that the child should not take any of those things. But again, the rule is that all sugar must be taken in moderation, but the presence of sugar in one's diet does not accelerate the progress of a cancer.
Thank you, Dr. Rena. So foods like rice and yam and other starchy foods can be taken by patients who have cancer?
Yes, perfectly fine. They, as a matter of fact, they should take those foods because those are natural sources of good carbohydrates, that have very low glycemic indices. And so these are things that meaning that they don't spike the blood sugar suddenly, And so these are foods that really they should be eating. So a child with cancer should not avoid carbohydrates.
Thank you so much, Dr. Rena. Mrs. Oyebusi, you have your hand up. Would you like to ask a question?
Good afternoon.
Good afternoon.
Can you hear me? Good afternoon, everyone.
Yes, we can hear you.
Okay. So I would like to say thank you to Tdcf for this great opportunity and for the work you've been doing so far. I'm actually going to be directing this question to Dr. Rena, and I'm very passionate about this aspect in terms of nutrition. So as a childhood cancer survivor, I had bucket lymphoma, and one of the most resonating words that I heard at the time was, do not take any food that contains folic acid. So it was very key for me that anything I was going to take at the time, I would check the label, as young as I was. But after I overcome the whole thing, and then growing up, there was no time I could get the proper advice on whether to continue, because it really limited my nutrition. I was always scared of eating something anywhere I go to, even the food I consume at home. So I just want you to clear the air on the effect of folic acid, taking folic acid, whether for those that are currently living with childhood cancer or survivors, and in what quantity would you take it that it will not have to affect or maybe increase the occurrence of the cancer. I just wanted to clear the air on that. I also want to learn from it because I still have my doubts about it.
Okay.
Thank you.
All right. Thank you very much, Adikem. It's a very important question, and I anticipated that this question would come up. Folic acid, of course, we know is a very important nutrient when it comes to cell division. And the reason why people are a little bit skeptical about one taking folic acid when one has cancer is the idea that folic acid, because it is involved in cell division and multiplication of cells, might actually give the cancer the resources to multiply and possibly spread. And even some of the drugs that we actually use to treat cancer, like methotrexate, are actually antifolates. And so they prevent or they inhibit the action of folic acid, thereby reducing the ability of the malignancy to multiply. However, if you look at the nutritional profile of a lot of healthy foods, including green leafy vegetables, liver, most vegetables actually contain a significant amount of folic acid. When folic acid is taken in doses that are along the lines of the recommended daily allowance for that child's age, then it is unlikely to have any adverse effect on the cancer. What you want to avoid is giving children folic acid supplements. So you don't want to give them those extra folic acid that comes in supplements, because the folic acid supplements usually are at quite large doses, which are about 5 milligrams. But the amount of folic acid that one requires in a day usually is even in micrograms. So by the time you start giving a child folic acid supplements, or you're taking or a child who has cancer is taking multivitamin supplements that contain folic acid, then it's important that one actually looks at the labels of such multivitamins, especially if they're on chemotherapy or they have just been diagnosed with cancer. Then you want to avoid those multivitamins that offer supra necessary, if I may use that term, excessive amounts of folic acid. But the likelihood of a child getting folic acid from a healthy diet that would be considered as promoting the growth of cancer cells is highly unlikely. Now, when it comes to food labels and packaged or processed foods, of course, the general rule is that one should avoid processed foods as much as possible. But usually, for foods that contain a little amount of folic acid, if one must eat processed foods, usually the amount of folic acid in such foods is also not so significant in comparison to what you might find in multivitamin supplements. So what I'd say is that please maintain a good, healthy diet for children who have cancer, because the amount of green leafy vegetables that they might eat will not be so contributory to the amount of folic acid that will promote the cell of growth of the cancer cells. Yeah.
Sorry, I asked a follow-up question. I was saying, so for survivors, what would you say? Should they still be wary of such, or there's nothing to worry about?
So for survivors, I imagine that survivors actually would be on follow-up, and so survival does mean that you have been screened, thoroughly screened, and that there are no residual cancer cells left anywhere. So for survivors, the only thing I would say is that, one, eat a healthy diet. Two, if you must take supplements, then discuss with your oncologist to decide if supplements that contain folic acid are required for you. But in terms of food labels and your eating of foods that contain folic acid, there are no restrictions, but you have to be careful about supplements because those are significant doses. Now, the only other thing, of course, that I want to talk about now is the idea that for women who are of childbearing age, folic acid is very important to prevent neural tube defects in such in children, in babies generally. And so a woman of childbearing age is required to take a certain amount of folic acid a day to prevent certain nervous system disorders in children. Now, the amount of folic acid that we actually get in our diet is actually enough to prevent neural tube defects, meaning that you have to be very deliberate about eating foods that contain folic acids. So for cancer survivors, a discussion has to be had in conjunction with the nutritionist and the nutritionist and your primary physician to determine if folic acid supplements are suitable for you. But if one was to give a blanket advice, I'd say avoid supplements altogether unless it is absolutely recommended. But please feel free to eat your regular healthy diet that contains green leafy vegetables.
Thank you, Dr. Rena. I hope Dr. Rena was able to answer that question because it was actually a follow-up question I had on supplement intake. A lot of people think that with cancer, the nutrition in food is not enough. They need to take their vitamin Bs and vitamin Ds and all of these supplements, even when there are no noted deficiencies. So we should focus more on our diets, on getting these things naturally from foods, and just focus more on taking in our green leafy vegetables and increasing our calorie intake, because this helps treatments, cancer treatments in itself. So a question we have for the nurse Rachel. So somebody is asking that what are the peculiarities in, because we don't know if you have any experience with treating adults with cancer, but what are the peculiarities? And what do you see with children, with treating children, taking care of children with cancer that people who deal with adults don't have to deal with? What are those problems and peculiarities that you face as a nurse? Thank you. Did you hear the question, Ma? You might want to unmute yourself if you're saying something. We can't seem to hear you. Okay, I think she's experiencing some technical difficulties. So we'll just go back to Prof. Sir. So there's a question coming in that with the current research, we know that there's a lot of research, especially with funding coming into to cancer research, especially in pediatric cancer research. Are we close to getting a definite cure? So somebody is asking that with cancer, especially with children, she has seen a case where the child was symptom-free for up to a time and then came down with recurrence, or they were seemingly told that the cancer had been cleared after the first round of treatments, and then a few months down the line, the child is coming back with similar symptoms. That with research going on, even around the world, are we close to a definite cure for cancer? Prof, if you could just help us with this question.
Well, thank you for the question. I can turn on my video, but the bandwidth will create some challenges. So please bear with me. Well, the first thing
That's
to say
fine, sir.
is that cancer is curable. So it's not an issue of getting close to definitive cure. In the industrialized nations, in the Western world, 70 to 80% of children with cancer are cured and cured for life. 70 to 80% are cured and they are cured for life. It is in the developing countries that we have a less favorable outcome for financial reasons. We don't have enough money, there's poverty, we can't buy enough the drugs, and then our blood bank is not well equipped to take care of the side effects that result from the chemo, from treatment. So certain times, patients with cancer die, not from the cancer, but from the side effects of the treatment, and sometimes also from infections due to inadequate laboratory backup to monitor the side effects. So cancer is curable and is being cured. Now, for us in developing countries, the children, just like it is abroad, it depends on the type of cancer and how. Can you hear me? It depends on the kind of type of cancer and how early they come. Some cancers have a good outcome. I mean, fairly good. For instance, one of the commonest cancer in Nigeria in children is Burkitt lymphoma. With Burkitt lymphoma, with a simple protocol that we have from the research that we did across 4 African countries, including Nigeria, at the 67% are cured. That means out of 100 children you treat, 67 will be cured, and 62 are cured for life. So we have cure. So when they come early, even Wilms tumor is the cancer of the kidney in children. When they come early, you can cure them with chemo, with surgery, and with radiotherapy. It's a multidisciplinary thing. If they come in an advanced stage, then the likelihood of cure is less. So the issue we have in developing countries like Nigeria is not just research. There are established treatment protocols that can cure cancer. The main issues we have are coming on time and having the fund to treat and to follow through to the very end. Even in America, there are certain patients that you treat for cancer, certain children, and they have relapse. Even in the best of centers, you may do stem cell or bone marrow transplant for them, and they will have a relapse. Second transplant, you see how it relapse. So everywhere in the world, they have relapse. There is cure, but it depends on the available facilities. And if we have the good facilities, the poverty is not there, or cancer is, the NHIS supports cancer, I mean, funding of cancer better than it is now, and people can afford it, you will have more cure rates. Cure rate will be higher in many of our children with cancer. Because the patient, in fact, in reality, many parents come early, but they come early, and because they don't have the funds, for instance, they have cancer in the eye, which is curable, 95% or so or more in other parts of the world. 95 to 100% of them are cured, cancer in the eye, all right? But because the parents have no money, they go back home, and when they return, the cancer has spread all over the body and is no longer curable. So if poverty is taken away or funds are released for treating cancer when they come early, the outcome, the survival, the cure rate will be much higher. But cancer is curable, and that should be very clear. Thank you very much.
Thank you very much, Prof. This is a question I'm faced with all the time. That is, can cancer be cured? Can cancer be cured? Are we just, pouring money into something and won't get, good outcomes? But it's good to know that there's cure for cancer even now, and even in our society. We just have to call on organizations and governments to help strengthen the health system so that all the supportive supportive measures are in place to help with the optimal cancer management. Thank you, Prof. Nurse Rachel, welcome back. Would you like to say something? I don't know if you heard the question the last time.
Hello.
Yes, hello, we can hear you, ma'am.
Okay, so I think you asked the question earlier on, but I've been having a lot of network issues, so I really didn't get the question you asked.
Okay, so the question came in that what is your experience when it comes to the peculiarities of attending to pediatric cancer patients as opposed to adult patients? What are the peculiarities or the differences or the peculiar challenges you face when it comes to attending to children with cancer?
Okay. Because we are actually dealing with children, it encompasses a lot of things. So it encompasses the family, which goes way down to the extended family, like their grandparents and the parents. Everybody is now involved in taking care of the child, as compared to adults cancer cases where you're actually dealing with an adult, but here you're dealing with a child, and so you are taking care of the emotions of both the children and the parents, trying to, you know, relieve anxiety. You're looking at emotional struggles, you're looking at financial struggles, you're looking at a lot of extreme and overwhelming emotions. So it's actually very taxing, but we try as much as possible as nurses to put in not just empathy, but sympathy, a lot of counseling, a lot of health education. And then you really need to communicate with children. If you really want to communicate with children, then you have to play with them because they also have emotions. And then we have teenagers sometimes. So it's really very taxing. There are a lot of emotions involved, the emotions of the child, the emotions of the city they come from. You have to just tackle everything. So apart from it's quite different when you're dealing with an adult, where you know that, okay, now this is just an adult. But yeah, you have to, you're not just taking care of the child, but you're taking care of the parents, making them understand, and at the same time carrying on your duties as a nurse. So it's a very emotional and struggle, like that's involved. So that's the peculiarity as compared to an adult who has cancer. I don't know if I answered your question.
Oh, yes, you did. Thank you for giving us that insight into your experience with children with cancer. We will be moving on to our life coach and childhood cancer survivor. Could you please give us a glimpse or your experience and from stories you've heard, or your personal experience on battling with cancer or managing cancer? How was it like for you growing up, adjusting with school and having to come out for continuous checkups? How was that like for you? Or if there are any stories you've heard with other people? Thank you.
Sorry, was that question for me?
Yes, please.
Okay, so sorry, please, can you repeat it?
So for Ms. Akapo, the life coach, what are your experiences with what are the stories you've come across with children with cancer in having to deal with adjustments to normal life? Most of their friends are in school and then they are missing out on school and missing out on exams, having to come into for checkup. What are your experiences with this? How do you think they cope with the with the struggle and with the battle with cancer.
Okay. Hello, everyone. Okay. Travis, can you hear me?
Yes, please, we can hear you.
Okay, so there is a particular guest, so unfortunate she has passed. So she had breast cancer. She was just 13. So I could relate with that. So most times I always tell the mom to allow, most times I just check up on her after her surgery, they have to remove her breast. Then she had radiotherapy. She didn't do chemotherapy. So most times, when I check up on her, the mom will be like, she's fine. But I notice whenever we talk, she will tell me the pain she's feeling, how she's feeling about the whole thing, that she's still young. She would love to have like a reconstruction, which could not communicate to the mom. Because said the mom might not really understand, but I love the fact that whenever we speak, she's always like related, okay, I'm feeling pain on the surgery side. Okay, I'll be like, okay, it's normal. But if you can't bear it, make sure you tell your mom so that you see your doctor and all that. It's always better to speak with the child directly. Probably because I had access and I made her free, because as soon as I started chatting, she would tell me, I'm fine. But later on, that I keep checking up on her, asking, how is school? Have you resumed school and all that? That she should be careful. She don't have to tell her classmates. She was like, some people know, some of her friends, and some are behaving some type of way, but she does not care. She's a very cheerful girl. She does not care that she does not care as long as she's fine. So most times she is able to tell me how she feels herself, unlike talking to the mom. But I don't know if most parents really allow that, you speaking to the child directly. Most parents want to be the one that give you information that they want you to know. But speaking with the child, I feel it will be a lot better because they know how they feel. Even if they cannot put the words together, saying it out, at least you can pick, okay, I can understand she's feeling pain. I'll ask her, how long has she been feeling it? Ratio of 1 to 100, how does she feel the pain? And all that. Then I'll tell her the question to ask her mom so that she can see her doctor. It will really be nice if I can have one-on-one conversation with the patient, not through the parents. I don't know if that would be possible. That is one of the challenges that I face, because story from the parents is different from what I hear from the child. Yeah, thank you.
Thank you, Mrs. Apako. So as much as we see them as children, they are also knowledgeable on the symptoms they are going through, on the things they are feeling, and then we should try to listen to them and try to get these things from them, because we can get a lot of information on what they are dealing with directly from them. We should not just dismiss their thoughts and their contributions to the process. Thank you so much for that. Mrs. Adewusi, do you have any contribution to this? What were your personal experiences growing up with and then battling with cancer?
Sorry, Dr. Maliki, before she answers that question, I would like to also add to for Mrs. Kemi Adewusi, like as a child growing up and having to, visit the hospital regularly and all of that, is there anything at all you would like to change, or anything you wish could have been done better that you would like to share? Because there are parents and caregivers also joined in now and listening. Was there anything they did then that you wish was done differently? Is there anything that you like for people to improve on while caring and taking care of their kids? Thank you.
Okay, good afternoon once again. Please confirm you can hear me, please.
Yes,
Okay.
we can.
Yes, we can.
Yes,
I'm
we can.
going to merge Dr. Layo and Coach Akapo. I'm going to merge your points together because I was actually going to say something on what Coach Akapo said on communication. So let me come from the angle of, is there something that I would have wished, or I wish that is done differently, and it's in terms of communication. So aside the fact that parents do not allow the kids to say their experience, one of the other challenges that I had was communication to me. So it was more like a lot of things were hidden from me, because there's usually this perception that when you tell a child, you're probably increasing the fear in the child. I was 8 at the time when I had my own, and I felt that at that age, I was a very inquisitive child, so I really wanted to know what it was. So for me, the word bucket lymphoma resonated in my head from that age, and I couldn't wait for the time that I could read about it and know what it was. I didn't know it was anything related to cancer at the time. So the fact that I was more informed, I was not made to understand my journey, was a challenge for me. So I had to bottle up a lot of my emotion, because this thing has a way of affecting your psyche. So for me, it was on that. And the fact that the country, so to speak, at the time I had it, it was as far back as 1998. I don't think the awareness was there. So I was seen as a different child. Sometimes I will be seen as being just exaggerating my feelings or my pains. So even in school, thankfully I had good support system, but it's not everyone that will understand the journey or what I'm going through. So in terms of being informed, a lot, even my primary health care center, I didn't even know what it was until I got to a state that they had to transfer me to a general hospital. So I would say communication from both the mother and the child, and from the healthcare worker to the child. It's something that I would appreciate that we incorporate in the system now. I don't know if it's working right now, but that's what I would appreciate. And then also for me, like I said, my experience was just more of a psychological part, because I had to stop school for 2 years. It came back, I had to go back for a follow-up treatment. So the face of my life was like stopped outrightly. And then I couldn't do or act like every other child. So it was like my childhood stage was not properly formed. So that was more of an experience for me, which one way or the other still has an impact as of today. I'm gradually getting out of it, but it's a process. That's just it for me. So that's what I would say from the aspect of what I would love for it to change and my experience in the whole thing.
Thank you very much. Thank you very much for that, Ms. Kemi. So I would also like to ask again, post-treatment and like following everything that's happened, are there times that it crosses your mind and you are restricted from doing certain things because of your diagnosis, or you just go about living your normal life? Do you have restrictions in your day-to-day activity, or does it cross your mind that you can't do certain things because of your diagnosis? So we'd like for you to share that so people can know. Thank you.
Okay. So from my immediate family, yes, I had restriction. And then it was basically because of the fear of, oh, she could be exposed to anything. Maybe while playing, something can happen again and I'm going to fall in. So my father was very protective, and then I would not play like every other child. I wanted to go to boarding school, so I was not allowed because there was fear of, oh, she can fall ill in school again. So that was a restriction from the family. The other challenge I had is eventually, because of the follow-up, I usually go to the hospital like every month, even after I was fully recovered. I mean, this was after like 2 years. I would visit the hospital like every 3rd Friday of the month. And so I had to stay away from school. It was it was a lot of pressure on me, and I couldn't just relate the love from my parents and my friends. I felt like, what is all this? So for me, it wasn't interesting. It was not an interesting journey. And then the other thing that is a challenge for me, or was a challenge for me as an adult, this is years back after I want to confirm that I'm totally free, is the stigma part of it. And then I would just use the opportunity to just say a very big thank you to Dr. Tdcf. She posted something on Instagram as far back as 2018, I guess, or 2019, which was talking about stigmatization of people living with cancer survivors. And then I remember that I bottled something in my mind about a guy that said, oh, you couldn't date him because I was a cancer survivor. And I chatted her, sent her the message. She welcomed me. She asked that we meet up. She spoke to me. So there's also that part of the fact that you are not free to share your experience. You're not free to really move in the society with what you've gone through or what you have. So that's something that I'm also very, I would say, very concerned about. For me, I would say that I'm now talking about it is in the past for me because I've mastered the art of not allowing it to affect me. But I know that there are a couple of people out there that are not able to get over things like that. So I couldn't play as a child as I would want to. I couldn't mix with my people. I was restricted in terms of food. That was what I was talking about, folic acid. And all of this was because of the love my family had for me, and they didn't want this whole thing to play all over. But if we were better informed, just like Dr. Lena was talking about in terms of taking vegetables. I mean, I grew up in a village, so to speak, that we had a lot of those things that are in enormous quantity and that you can easily find it. Perhaps I would not have been seen as, oh, she can't eat food like every other person. I was really limited. I hardly eat, and as of today, it still affects me because I'm too careful as to what to take or what to do. So that's what I would say is the challenge for me, or was, and is still a bit for me. Hello?
Yeah, thank you so much. Thank you. Thank you for your input so far. It's been really it's been an eye-opener, when you get to share your experience with parents and caregivers that are listening in, so they're able to adjust and make certain changes so they won't make not mistake, but so they won't do the same thing to their own kids and with their words. But I would like to say that is there anything you would like to tell the caregivers and the parents? Sometimes these things, this diagnosis can be devastating and all of that. Something just to keep them going, from your own point of view. It's a lot on the financial aspect and the mental part of it. Is there any word you like, encouraging word or anything you just like to tell them so they know, like, it's not just their child or their relative going through this, that people that have gone through it and they've survived? You're an example. So would you like to just tell them something? Thank you.
Okay, so basically I would just say that it's not the end of the world, to be honest, and then communication is key, just like I said. It will be very important for parents to speak to their child and then try to get into it, because one of the challenges for me, I related back to me, was the fact that I was not when I started noticing the challenges I had, people didn't take me serious at first because they felt like I was just exaggerating. So we should try to just listen to our kids, no matter how little of the information they want to share with us, no matter how busy we are, so to speak. As much as possible, we should create time to listen to our kids, because there are a lot of unspoken words, and then be observant. I had my bucket lymphoma, and the swelling was at the abdomen, and this was already on, but my mom didn't notice on time that my stomach was growing big at one part. So being observant, taking note of little changes in your children is very key. And then I would also say that at that stage, when eventually you find your child being diagnosed with cancer, it's not the time to really break down. You just need to be there for the child. That's the best thing you can do. And that I would say that is the best support I had. I know that financial part of it may make one to feel demoralized, but you just need to be there for the child, because the child is not someone that is able to hold as much pain as an adult. So if I want to look at my treatment, how difficult and how painful it was, I would say that having the right people around me was the thing for me. Sometimes I would have my uncles holding my hands through my chemo injections, just trying to help me go through that pain together. So just be there for the child. Prayers goes a long way, I must confess, it goes a long way, but don't break down. There's nothing, just like the doctors have advised us and have told us, cancer has cure as much as especially if it is detected early. So That's just the basic thing that I would say. Communicate well, observe your child, be there for the child. That's all.
Thank you, Ms. Kemi. Thank you. Your experience is encouraging. From what you said, I know that the key ingredients to having a good survival period from childhood cancer is a good, very, very good support system. Your family and social support is very important. And also from what Prof has said, a good health system with the right specialists taking charge of your treatment with good funding, and we can have achieve cures with children with cancers, and for them to go on to have seemingly normal lives even afterwards. Thank you so much. So we have some questions in the chat box that I'll just be running through, and then it seems like the questions are for Prof as well. So someone asked that for people who started cancer treatment, especially with chemotherapy, it seems like in their beginning stage of treatment, they seem to be doing well, they recover, and they're looking good. But all of a sudden, sometimes the condition takes a turn for the worse. That what could be the cause of this? And also, is there a benefit to risk assessment we give patients to see if they qualify to have chemotherapy treatments? Prof, if you could help with this.
Well, thank you. We don't do benefit to risk giving chemo to children. Some cancers have chemosensitive. That means they will respond to chemotherapy. Some are not chemosensitive. That means they will not respond to chemo. So what we do, and then some also are radiosensitive, which means to respond to radiation or radiotherapy, and others are not. What we do is to let them know what the likely outcome is, and whether, so they will then weigh the risks of undertaking the chemo for their children. Or for instance, if for instance, a type of cancer has a cure rate, type of cancer and at a particular stage has a cure rate of like 80%. That means if you treat 10 children, 8 of them can be cured. That's a good thing. So we encourage the parents to go on. But if the child comes in at an advanced stage of the same cancer, but at an advanced stage in which out of 10, only 1 can be cured, we also let the parents know, and we lay the cards before the parents. We also ask them their family situations, their economic power, how many children they have, what work they are doing, so that they don't end up spending everything on one child that has a high risk of dying. In fact, sometimes the child dies and then the entire family is impoverished. We have seen families that have sold their cars, some sold their landed property, and so many things. The parent that still the child in the hospital loses her job because she's away from work for a long time. So one parent loses her job, the parent lose their landed property, their assets, and in the end, the child dies. And then the other remaining 2 or 3 children who are alive, who don't have cancer, then suffer along with the rest of the family. So the final decision is taken by the parents. What we do is that when the outcome is not encouraging, we just let the parents know these are the chances. But we'll advise them when the outcome is very poor, we'll advise you, please avoid selling everything you have. Avoid selling your cars, avoid selling your house, avoid selling your landed property. Remember that you have 2 or 3 other children to take care of and yourself as well, so that you don't spend everything on this child whose prognosis is guarded or chances of survival is low, and then everybody themselves. So we often counsel them in that direction, but they should take the decision by themselves. That is, however, sometimes in which the disease is so bad, in which it is terminal, that we advise them, we counsel them against chemotherapy. So say, even if you go to the United States, with this stage of this disease, this child cannot be cured medically, except you use pray to God or whatever it is. But medically, this stage of this disease cannot be. So we tell them point blank, and then but we can transit them to palliative care. What does palliative care do? It gives the children a better quality of life, a pain-free life. They have fun. At least whatever years they have left or whatever months they have left in their life, they have care and they live it in quality. So that's what we do. We communicate with the parents about the children. The other point in this regard is that, like was said by the previous speaker, communication. Certain parents do not want their children to know that the child has cancer. Children that are of age, especially the older adolescents, they should know. And when they don't know, they don't cooperate well. Some will even stop eating. Some will reject the drugs. Some will reject their food, and in the end they will die. But if you communicate with them, they will cooperate better, and the chances and the outcome will also be better. So that's what I'm going to say at this point in time. One thing we don't do is that we don't play God. Say this one, I'm giving you 6 months, like it's often said in certain Nollywood movies. 6 months, you are dead. 3 months, you are dead. No, we don't say such thing, but you are not God. We only say these are the chances. This percentage is likely to survive. And let's not hope that your child can fall into those that will survive, but these are the pros and the cons. And the economic effects of going ahead with the chemo, bearing in mind your earning power and how many children you have and the rest of the family. Thank you.
Thank you so much, Prof. So from what you said, there are no absolutes when it comes to cancer treatment. Each case is taken individually, and then treatment protocols and treatments is designed according to the individual patients, the economic power of the caregivers, and the prognosis and stage of presentation. Thank you very much, Prof. Someone else was also asking briefly if any risk factors or any risk factors to look out for when it comes to prevention of cancer in children. Are there risk factors that make people prone to having childhood cancer, and how can they be prevented?
All right, thank you very much. There are actually some risk factors that dispose to childhood cancer. One of them, surprisingly, is malaria. All right, the most common cancer in sub-Saharan Africa is pocket lymphoma, and that's associated with malaria. But what we have seen is that with proper and adequate treatment, you can reduce the incidence of that form of cancer. For instance, in Ibadan, where I practice, pocket lymphoma was the most common kind of cancer. But we realized that over time, it improved. Over time, the incidence reduced. In fact, now, unlike initially, which you may see 20 or 30 cases of pocket lymphoma in a 1 year period, now you may see 1 or 2 cases maximum, and more 3 cases in 1 year. And we began to see this trend in a period when malaria was being treated with ACT. So malaria is not something that is a risk factor, and when treated early and properly, can result in a reduction in that type of cancer. Other risk factors include the radiation. Minimize how much radiation that a child is exposed to. Now, in some other cancers that may occur, the prevention occurs in childhood, for instance, hepatitis B, and results in cancer of the liver, but that type of cancer of the liver occurs in adulthood. But the child should have been immunized as a child with hepatitis V vaccine. When that is done, they are protecting that child from developing liver cancer as an adult. The same thing with cervical cancer. They receive the vaccines as adolescents, all right? And then it prevents them or protects them from having that cancer of the cervix when they become adults. There are a few other conditions that they disclose are risk factors. Even the cancer drugs themselves, the chemotherapy drugs themselves can result they are used in also being
Sorry, Prof. I think the network connection might not be strong because it seems to be breaking up. Oh, I think yeah, I think Prof's network isn't strong, so I don't think it's on the call anymore. But thank you so much for your contributions, Prof. There are not a lot of risk factors when it comes to childhood cancer, especially in terms of prevention and screening. But looking out for things like treating and prevention of malaria, which he has said causes one of the commonest type of cancers here in sub-Saharan Africa, which is buckets, and then just general well-being, general healthy practices and lifestyle choices, and then early detection. So, and then because that's very important, the earlier the people present to hospital, the better their chances and better the prognosis of treatments. Thank you so much, Prof, and thank you to all our speakers. I have a question for Coach Akapo. So as a breast cancer survivor, I'm going through all of the treatments. One thing that we have come across is stigma with surgery, especially mastectomy, having to cut off your breast in course of treatment. I've seen patients who have refused vehemently to not have surgery or mastectomy, and I've gone on to have metastatic diseases because of this. In your experience and maybe in your discussions with other women, what do you think are the causes of this? Why would we want to, when it comes to varying the benefits of having the surgery to keeping the breast? Why do you think this comes about? Why do you think women have this hesitance with surgery? Thank you. I think you're muted, Ma, so we can't hear you.
Okay, I like using myself as an example. Then I'll talk about other stuff. So when I was told I have to use a breast, initially using a breast was not really a problem to me. Surprisingly, people would be like, that is so rare. I was like, because the breast is still gonna kill me. So why hold on to it? So that was how I felt. But relating with other women, even elderly women that okay, they are very old and they are not bearing children again or anything, they still feel some type of way losing their breast. Because I can remember even talking to an elderly woman, she still feels she has done her surgery now like 3 years, she still feels so bad every day. She has not really embraced her scars. She has not really moved on past losing her breast. I'll just keep encouraging her, even her, because her husband accompanied her to the clinic. Just want to be like, look at a young girl. She's one that is encouraging you that you are elderly. That Then I now told the husband that if he can't save that, he should allow her to heal in her own pace, that we are all different. The way we see things are different. Whereas some people, they will refuse treatment largely because they do not want to lose their breast. And then at the end of the day, I know so many people that are held on to their breast and they are fat. The thing is, the stigma that comes with it. Because relating to so many married survivors is a whole lot. It's just probably maybe few out of maybe, okay, let me put in a percentage, maybe like 20% of men really understand. And I always tell them to communicate with their husband. I said, fine, it's hard. And it could be anybody that what these tables were on. Because I know so many cases that their husband actually left them. Because even some, the husband will tell them to their face that it cannot be staying with someone that have one breast. As if the marriage is tied to the breast. Then I'll encourage them that your life is more important. That holding on to the breast will not, the breast is still going to kill you. The best thing, the best decision you can ever take is to let go of the breast, which I know is very, very hard. But that is the only way you can stay alive. Thank you.
Thank you, Coach Akwapo. Because I have heard cases like this where the women might be willing to go through the surgery, but because of they are worried about what their husband would see, and most of the time we see them go on to having progressive and metastatic diseases, and then eventually the husband still goes. So yeah, so one thing is to take our health, our personal health paramount above all things, because when there's life, it's when you can deal with all the other things that come with it. Thank you very much for sharing your perspective. There's a question in the chat as well. It says that for a child, if a child has been diagnosed with cancer, what are the chances of the siblings having it also? And is there anything that can be done to determine their chances of having cancer? Prof. or Dr. Rena, Dr. Alakaluko, you can answer this question. If a child has been diagnosed with cancer, what are the chances of the siblings having cancer? And is there anything that can be done to know what the chances are of the children coming down with cancer?
Dr. Maliki, can you hear me?
Yes, Dr. Rena.
Okay, great. So, so before I go on and answer the question, let me just address something. So, Dr. Chibuzo Soji, yeah. So I think he, I mean, I might have created the impression that I was advocating for multivitamin supplementation, but no, the question was specifically on folic acid, and what I said was that please avoid all folic acid supplementation, and then I think I might have said avoid multivitamins in which folic acid is contained. But I think the recommendation really is that all multivitamin supplementation should be avoided in children who are being treated for cancer or who are on chemotherapy, because it can interfere with the treatments, including the therapy and the chemotherapy. So the specific question was about folic acid. So avoid supplementation of folic acid altogether and avoid multivitamin supplementation, just to be clear about it. That being said, when it comes to the genetic or the risk of a sibling having cancer, it can be a difficult one, because there are some cancers where if you want to study genetics very well, the best set of people to use is actually a set of monozygotic twins, meaning identical twins. And there are some cancers that, yes, if it happens in one of those twins, it's likely to happen in another. Now, when it comes to siblings, even if one sibling has, because there are some cancers that occur as a result of what we call a two-hit model, such that there is a genetic error and then there's an environmental exposure. And so if there is a genetic error, but there is no environmental exposure to create the cancer, then even if a sibling has that same genetic error, but does not have that environmental exposure that can trigger the occurrence of the cancer, then that sibling is unlikely to develop the cancer. So in terms of chances, it's difficult to actually put a figure on it and say that, oh, the chances are high or the chances are low. But what I say is that there is a risk that if one sibling has a cancer, the other might, depending on if they inherited the same genetic error that could lead to that particular cancer. Meaning that I think the advice is that if one sibling has a cancer and is a cancer that can be screened for, especially like a retinoblastoma, it's good that the other siblings begin to go for screenings or go for regular health checks so that if there is any kind of evidence of the cancer occurring, it can be detected.
Thank you, Dr. Rena, because I had seen a case of a family where the child had Wilms tumor, and then they made sure that the child wasn't using cups or spoons or sharing the same space as the other siblings because of transmissibility. There are some people who think that it's communicable cancer, especially when it comes to children, but it's a genetic thing, like Dr. Rena has said. When the environmental and genetic factors come into play, that's when you can have the development of cancer. And then for those that can be screened, they can be screened. These are conversations you need to be having with the pediatrician, the consultant pediatrician, when a diagnosis has been made. So someone else is asking if all children must undergo chemotherapy or radiotherapy for all types of cancers. I think Prof mentioned something about each cancer being taken on a case-by-case basis. The treatment protocols and treatment guidelines have been stated already, and then based on the stage of presentation and other prognostic factors, that's what determines what treatment modality the child will be going through, if it's surgery or chemotherapy or radiotherapy. If you have any other questions, you could still send to the chats for the panelists who are still around. Just one question for Dr. Alakaluko. So somebody sent in a question earlier on residual disease. So for a child that has had surgery for maybe a Wilms tumor, and then before the initiation of any post-op or post-surgery treatment like chemotherapy or radiotherapy, and imaging shows evidence of residual disease, is the child taken back into surgery to take out the rest of the tumor, or what's the treatment modality when it comes to cases like this with people having residual diseases in a short period of time after the initial surgery? Dr. Alakaluko, if you could answer this.
Okay, thank you very much, Dr. Maliki, and thank you for the question. So in such a case where the patient has residual disease, what the person means by residual disease is that we could not excise everything during the surgery, okay? And there are many factors that could lead to that. Sometimes the tumor is encasing major organs and it's not wise for you to be over-aggressive. Otherwise, they will lose the life of the patient. So in that case, you know that it's an artery resection. That means that you are leaving a gross the disease behind. And the reason why you are doing that is to debulk the tumor to the best possible safe margin you can. And then you expect that the patient should have chemotherapy and radiotherapy. And then if, and this will not be usually very large anyway. And then if that is done, you expect that to shrink over time. However, after the completion of the treatment course, that means the courses of chemotherapy, for instance, if it's a Wilms tumor, for instance, you have done chemotherapy for post-resection 21 weeks, neoadjuvant therapy, and then you have also gone for radiation therapy. And still yet the tumor has not finally shrunken, or the size is not increasing more than what you left behind. Then you plan for a second look surgery. And in that case, you go a second time after this modality of treatment have been done. And that the aim of that is for you to have a more thorough resection, while you are still very careful not to jeopardize the child's life during that surgery. I hope I've been able to answer your question.
Yes, sir. Thank you very much. The person also wanted to know that in a case of recurrence, so after surgery, patient has had some chemotherapy and radiotherapy and has gone on to be symptom-free, but later comes down maybe some months after with same symptoms again. Is surgery at that point advisable?
Thank you very much. So usually we re-evaluate the patient, we do our imaging, magnetic resonance image, CT, computer tomography scan will be on the air, and we want to correlate the post-surgery image with the present image. If it shows evidence of, mass or a tumor still growing, we go for a second look. Go for a second a repeat surgery, and the aim of that surgery is to debulk as much as possible, because for chemotherapy and radiotherapy to work effectively, you need to have the tumor not.
Sorry, sir, we didn't get the last part. I think the network went off a little.
Oh, sorry. I meant to say that when we have a residual disease, the aim, the goal is to still go for a second look surgery. Surgery will still come in place, and the aim is to debulk until you have, probably a microscopic remnant, not a gross remnant, not something very sizable, so that your chemotherapy and your radiotherapy can work effectively. Did you get that? Over.
Yes, sir. Thank you very much, sir. So it also speaks to the multidisciplinary approach when it comes to cancer treatment. Our radiology has to be on point. For the surgeons to have the necessary tools to properly assess the stage at presentation and to know the treatment, the next line of action when it comes to treatment. Thank you very much, Dr. Alakaloko. I think Ms. Kemi has her hands up. If she can, you could ask a question.
Okay, thank you. So I don't know if any of the doctors actually spoke about this, but I would like more insight on the after effects of chemo or radiotherapy. The immediate after effects or the long-term effects of anyone that has gone through this. Is there something that you begin to experience in life that you should take note of as a result of some of the chemo drugs or injection or treatments you had at the time you were treated? So I just want someone to talk about it. You guys okay? Did you get my question?
Yes, please, Dr. Joseph. You could, if you could help shed some more light on this.
Okay. Sorry to cut Dr. Joseph short. I just want to ask all of the questions so she can answer everything all at once. Okay, so she's going to answer that. Then there's a question from the audience as to why doctors don't really explain things to their patients. So somebody wants to know if there's any reason behind that. And then also, being in a low middle income country, that's like a disadvantage already. And then you have to treat patients with the same disease as those in developed countries. Are there protocols tailored towards patients in this low middle income country? Are there protocols that have been tailored to treat the same cancer as the one that occurs like in both zones? So we'd like to know if there's like a special protocol for Nigeria, for instance, and another special protocol for patients in USA with the same disease. So we'd like to know that too. Thank you.
Okay, so thank you very much, Dr. Fagbemide and Maliki. Good evening, everyone. I've been in and out because I'm somewhere in the clinic. But I'm glad to be able to just speak to some of the things that have been asked. So the first question, asking if there are tailored protocols for LMICs. Yes, there are. Maybe not extensively, but for at least the common cancers. So for example, we have the NCCN harmonized guidelines And what they've done is basically taking the NCCN guidelines is what every oncologist, well, not all over the world, because in Europe, they use the European guidelines, ESMO. But NCCN is what most clinics in Nigeria follow. And these guidelines are a living document. They're online and they're constantly updated and reworked to reflect changes that are going on as knowledge is coming out. And we have the harmonized guidelines, which are tailored for Africa. There's some for Asia, but there are those for Africa as well. And what they've done is taking those standard guidelines and sort of considered what is available and what is not. So in a place where you would have maybe stereotactic radiotherapy as a treatment, they know that that's not available in your LMIC. So they will shade that out in gray to let you know that this would have been an option in, a country that has it. But since you don't have it, you can do this. And the point is that alternative is not necessarily inferior. It's possibly just maybe cheaper, easier to access, more available. Doesn't mean that the outcome from that is going to be less acceptable than if you had the other thing available. So yes, that guidelines like that. And then right now there's in development, there's something called the ARIA, is an adapted guideline for pediatric cancer patients. And it's in progress, being developed by St. Jude and a whole global team. And again, what they're trying to do is take what is standard, this is the standard of care, but also try to make sure that, countries with different levels of resources are able to adequately treat their patients following those guidelines. So that's what the ARIA adapted guidelines are. So yes, there are some guidelines, maybe not for every single condition under the sun, but at least for the most common ones, you can find those tailored guidelines. So that was the first question. I hope I've answered that. The second question as to doctors explaining things properly to their patients, I think, if we're being honest, there is definitely some cultural influence in that regard, in that traditionally our society has sort of created that impression where the doctor is all knowing and you really just put yourself in their hands. And I'm certainly not saying that that is right, but that sort of is a bit of some cultural background to it. And as things change and people become more involved and more interested, well, maybe interested is not the word, let me say more involved, more exposed, enlightened, that will change. I think if I was going to give advice to somebody who is on the side of receiving treatment, what I would say is ask questions. And I always tell people, if you ask your doctor a question and the person is afraid or reluctant to answer you, then that's a red flag. And it doesn't have to become a quarrel. It can be, you can express that red flag, and still get your answers and say, listen, Dr. Joseph, you have not answered my question. This is my question, and I would really like for you to answer it. And the other thing to remember, I always tell people that remember that your doctor is also a person who, okay, so I'm doing an observership somewhere out of the country right now, and my colleague, a fellow radiation oncologist like me, is seeing maybe 6 patients in one clinic, whereas I'm seeing 40. So when you have 40 people that are coming to see you and 10 of them are waiting outside the door, you can feel a little bit of pressure to rush. So it can happen where I don't have to really take the time. So you sometimes have to be the one to make your doctor pause to say, Dr. Joseph, I know you're in a hurry, but I have questions and I need you to answer. And any reasonable person in that situation should be able to take a breath and say, okay, I'm sorry, I apologize. Tell me what are your questions and let's go through them. So just try to remember that your doctor is under pressure as well. And if we're kind to each other, if the doctor is kind to your patients and the patient is kind to your doctor, if you can bring some consideration into that arrangement, you think, okay, this person has a lot on her plate, but I need my questions answered, and present it that way. That, listen, I know you have a lot on your plate, but I have questions and they haven't been answered. I would really like you to take some time to answer my questions for me. So I'm not making excuses for a doctor not educating the patient adequately. You really, the whole point of informed consent is the person has to by the way, can everybody hear me? I'm not just talking to myself.
Yes, we can.
Okay. So the whole point of consent is that you do have to adequately explain, and the person has to consent to something that they understand all of the ramifications. So I'm not making excuses for not doing that. I'm just trying to explain that, again, in a limited resource setting, you have to sort of understand what some of the challenges are and be able to overcome those. So that's what I'm going to say about that. And then the first question was, okay, side effects, yes. Again, that's a whole textbook. of answers because it depends on what was treated, who was treated, how it was treated, when it was treated, so there are a lot of factors that play into what the effects are going to be. So starting with it depends on the type of cancer that was treated to begin with and what type of treatment was given. So did you have radiation? Did you have chemo, surgery? If you had chemo, which specific medications, which specific drugs? So there are some drugs that have neural side effects that will cause maybe long-term neuritis or long-term tingling, pins and needles, for example. Or there are some drugs that we call ototoxic, meaning that they can affect hearing, they can cause impaired hearing. There are some that are nephrotoxic, meaning that they cause toxicity to the kidneys. So it depends on the specific drugs that we're taking. It depends on the doses of those drugs. Again, so you have what you call maybe like a cumulative dose. So it depends on what dose of treatment the person received, over what period of time it was received. It depends on if we're talking about male or female. Again, because sometimes when we discuss fertility, the threshold levels can vary from male to female. It depends on where it was treated. For example, if you give radiotherapy for retinoblastoma is a cancer of the eye. When you treat with external beam radiation, you can cause a slightly higher risk of that person developing bone cancer in the long term, that child developing bone cancer as an adult. That effect will not be seen if I treated a Wilms tumor, which is in the abdomen. So it depends on what part of the body the treatment was delivered to. It depends on what type of treatment it was. It depends on how long it was, what dose of treatment was given. So those are factors to consider. However, this is what I would say if I really wanted to summarize it. I would say that for every person who is treated with cancer, there is a balance between we're trying to cure the disease or we're trying to control the disease and we're trying to make sure that the person has a good quality of life for the rest of their life. Particularly with pediatric cancers, because we do have a high chance of curing a good number of them. Long-term side effects are a major consideration, and that's something that you should always have a conversation about. So the physician, the oncologist, has a responsibility to sit down and explain what to expect in the long term and in the future. However, many people who go through cancer treatments as a child go on to live wholly successful, full lives. There are side effects to monitor for, but there is nothing stopping them from living a well-rounded life, in the long term. That's what I would say.
Thank you very much, Dr. Joseph, for that in-depth. Thank you very much, everyone, for joining. I know there are so many hands up. Thank you very much, Dr. Maliki, for that wonderful moderation. Thank you, Dr. Funmilayo Fagbemide. So I see Dr. Brown's hand up. Sir, I don't know, you just want to share one or two things in a few minutes. Sir, over to you, sir.
Yes, thank you very much. I'll be very brief. Just on the same point of doctors not talking to the patients or not telling them the whole truth, it is our culture, that makes doctors behave that way sometimes. I've had a child that had a cancer, and I laid the cat there before the parents and told them the chances and said, let's go ahead, they are Christians. I even prayed along with them. And they went on to report me to their acquaintances. Dr. Brown said, this child will die XYZ. So I became cautious. All right. I have another child that I had treatment from Ife, had a relapse, went to Akure, treated again, had a relapse, came to UCH. I treated again, did well, and had a relapse. And I told them the outcome was poor. But they insisted in going to South Africa, I said, South Africa don't likely help you. Prognosis is poor, but they still went to South Africa. But the doctors there said, look, if you come to South Africa, your child will die in South Africa. So better remain in Nigeria. And the father of that child became very angry that South Africa men.
Yeah, I think, okay.
death. It's only bad news. Our culture here is like we don't accept reality of death. And so doctors very often shy away from saying the whole truth so that it doesn't get misconstrued and it results in something. And very often you see some patients that are referred to palliative care. And as they get there, palliative care doctor sees the letter and says that you have a terminal illness and your doctor can't treat you any further. And the patients are shocked because the surgeon never told them that. He just gave a letter to palliative care. So it is because of our nature of not wanting to hear the whole truth. We don't want to hear that the patient may die or whatever it is. So some doctors end up holding back information because they don't want the family to see them as being bad individuals. But we must strike a balance and learn how to give the information, give them as much information as they need in a way that hopefully they will accept and know how to handle. Thank you.
Thank you very, very much for that additions. We really appreciate it. Thank you so much, Dr. Brown. Dr. Brown is the president of Nigerian Association of Pediatric Oncologists. Thank you very much, sir. We really appreciate your presence. Before we wrap up quickly, I just want to quickly recognize the presence of a few people that joined us. I'm going to start from Ayo, Miss Ayo Balogun. Ayo is from Miss Ayo Omotola from St. Jude. Ayo.
Hi, everyone. Good afternoon or good morning. This has been really amazing, and we're glad to be here. So I'm representing St. Jude's Children's Hospital here.
Thank you very much. I was glad to have you on the call. Also, we also have the founder of Akopi Foundation, Mrs. Adekoya Kemi. I'd like to share one or two words, ma'am. Thank you.
Good evening, everyone. Can you hear me?
Yes, we can. Yes, we can.
Okay, good evening. Thank you so much. It's really been very insightful. As I always say, childhood cancer is everybody's business. So we need to talk more about childhood cancer. We need to get more people involved and spread the word out there that it can be cured and these children need our love and care. Thank you to the Doctors Cancer Foundation.
Thank you very much, ma'am. Also, we have the president of Nigerian Cancer Society here, person of Dr. Adamu. Thank you so much, sir, for joining us.
Yeah, hello, can you hear me?
Yes, we can, sir.
Yeah, I actually want to appreciate the Doctors Cancer Foundation for assembling this area of caregivers, professionals in their own rights, and the cancer survivors for telling us their stories. And I want to sincerely appreciate you for what you are doing alongside other childhood cancer foundations are doing. And like Kemi said, childhood cancers should be everybody's business, because if adults with cancers will have a lot of mental imbalance as a result of the disease, you can imagine what a child goes through. So another thing is that we are making a lot of grounds. We are gaining a lot of grounds in the area of childhood cancers, because we are still around the week of the World Cancer Day commemoration. And for those of you that witnessed the last ministerial press briefing I held on Monday last week, the Minister of Health made some categorical statements regarding childhood cancers, where he said the Cancer Health Fund that is currently operational in 6 pilot hospitals will be expanded to cover more hospitals. And again, he said the 3 cancers, the common cancers that we have, they are also making effort to expand the scope to include, he mentioned particularly childhood cancers. And I think that is all as a result of awareness. It's a result of what foundations like the Doctors Cancer Foundation are doing on childhood cancers generally. So I commend you for commemorating this International Day of Childhood Cancers. So thank you very much once again.
Thank you very much, Dr. Adamo. And everyone that is here, thank you so much for joining us. Because of time, we can't mention everyone. 3AM Foundation, everyone, thank you so much. Medicaid Foundation, everyone that joined us. Chai, Clinton Access Foundation, thank you everyone that joined us. We really value this time. Thank you so much. On behalf of the management and the children of the Dorcas Cancer Foundation, thank you and do have a wonderful evening. Bye-bye.
Thank you. Bye.